Hi there, I'm Dave Dennis, Medical Services Officer with Walton Valley Fire and Rescue. I'm here today with Dr. Daya.
Hi there again.
We are going to talk about a change to the altered mental status protocol, in particular the CBG level, and then some of the signs and symptoms of hypoglycemia. So we brought for discussion at the Protocol Development Committee this year some concerns or some questions we had about the current protocol. As you remember, the current protocol talks about treating under 100 as far as the CBG level. So we were wondering if maybe that needs to be lowered to 80. And then should we define minimum treatment endpoints for blood glucose levels? Especially we have a lot of these patients who are refusing transport. Should their level be up to a certain point before we let them refuse? And then should we define some of the symptoms that are suggestive of hypoglycemia? So just take a look at the previous protocol. So this is 2017. And again, the endpoint or the top point of treating was 100 in a symptomatic patient. And then it talks about if the CBG after 5 minutes remains low and the patient remains symptomatic, to repeat that, but we never really defined what symptomatic meant on that.
Or low. And I think that this is some of the things that we're trying to clean up in the protocol, realizing there's a lot of sort of gray areas that are not clear. We're trying to give you some better definitions. 100 always bothered me because if you were technically in my ED and you were talking to me and you had a little confusion and your sugar was 99, I should give you glucose, but I don't, because I don't, in my mind, consider someone hypoglycemic until they're much lower. And then the NASEMSA protocol, which is the National Association of State EMS Medical Directors protocols, use a much lower threshold. So we decided we'd try to look at what evidence is there out there that might help us guide us in terms of defining what's a good threshold.
So this is how the new protocol will read. So we're still treating less than 60 or less than 80 now in a known diabetic patient. So that's the change there. And then if the patient is refusing treatment, we made a lot of changes last year with that. We talked a lot about those patients who are on oral hypoglycemic agents. Be very cautious about those patients who are refusing. But never really defined a value of what their blood sugar should be. So we added that back into the protocol where the patient's blood glucose level should be above 80 before we let them refuse. And then we just threw at the bottom of the notes of precaution section some of the symptoms associated with hypoglycemia.
Correct, and I think that what this is doing is giving you that added clarification that I mentioned earlier. And remember that symptoms change in patients, so particularly long-standing diabetics, they get something called autonomic neuropathy. And unfortunately, they often will not have the palpitations and sweating and other things, because what happens is their autonomic nervous system begins to fail from the diabetic nerve complications that they suffer. So they sometimes just get confusion or altered mentation or have behavioral issues. They won't be sweating. The person who's had diabetes for a much shorter time will almost always have those symptoms.
So there was some science behind this. We took a look at this particular journal article. If you want to talk about that a little bit, Dr.
Sure.
Daya.
So when you try to find some evidence to say where do these numbers come from, why does one protocol say 70 and why did we have 100 and did it make sense? So we actually went back, and this is a nice study done by Dr. Boyle and colleagues from 1988. He actually did an interesting study. He took a group of patients who were diabetics who were poorly controlled, along with a bunch of normal people, and he essentially brought them in. Poor control, as you can see, was defined by hemoglobin A1C, which is something measuring your blood more than 10%, normal is 6% or less. And he put them all on an insulin drip, initially with glucose to keep their sugar at least 100. And then he started them on an insulin infusion and intentionally gave them insulin to see when would they start to experience symptoms when their sugars dropped. And as their sugars dropped, he took them down to 90, 80, 70, 60, and 50 over 6 hours. And at the same time, he also had a bunch of controls in which he kept the sugar at 100, and they were all blinded, didn't know what was happening, and he was basically sampling things throughout the study period to see what happens. So you can see this next slide basically on the left-hand side shows you the fact that these were the symptoms that we're looking for. So sweating, heart pounding, shakiness, nervousness, hunger, tiredness, dizziness, and you can see the rest on that list. These are some of the things that are now in the protocols to sort of give you a sense of the kinds of symptoms people have. But I think what stands out is two things. Number one, that middle column tells you that if you're a non-diabetic individual, you've never had diabetes, you're not on insulin, that almost always their symptoms don't appear until their level drops below 60. So under 60 in anybody is not normal, and that should be a treatment threshold. But you can see on the right that diabetics get used to living at a higher sugar level. And for them, the symptoms of hypoglycemia appear much earlier. They're at a much higher level. And the threshold there is about 80. And so you can see that if you had 80 or less, you would catch those. And so I think based on this, you can understand that why we have 60 for all comers for hypoglycemia. And in diabetics, it should be 80. And that's kind of what we picked. And that's why you also then target 80 as the optimal treatment threshold as well.
Right, and this kind of explains what you were just saying.
Correct.
That the diabetics are going to be experiencing symptoms at a little bit higher level than
right.
the non-diabetics.
And that's because their body gets used to higher sugars, and so they tend to run at a high level. So when their sugar, if they're running 150 all the time, for them, they become hypoglycemic at a much higher baseline level.
And as you mentioned, we looked at some of the national standards as well. And so the national standard being 80, and that's what we kind of guide ours on as well.
Right, and I think the things to remember here are that number one, diabetes is common, it's increasing, and it's going to continue to increase. You're going to see a lot of these individuals. Many of them will get hypoglycemic. They will correct with your therapies, either oral or IV glucose. And then the question will be, are they safe to have a refusal? And I think you need to go through the refusal portions of this to be quite, to be careful to make sure that you're actually looking at all the things that we want you to figure out, which is, why did this happen? Was it corrected? Will it happen again? What are the risks to the individual? And are they have capacity, and are they competent to refuse? All those things must be thought through, because there are some hypoglycemics that if you don't pay attention to the details of what's going on, they will have recurrent hypoglycemia. And remember, your brain is totally dependent on glucose and oxygen for nutrition. If you keep getting hypoglycemia, those are going to give you small hits to the brain that ultimately are not good for you or your patient.
And another language addition, just real quick, is we also added that they should have a reliable adult staying with them as well, just to monitor them. Thanks for watching, and remember, the protocols will take effect on January 8, 2018. Thanks.
Thank you.